Very good afternoon to everyone. I really thank the organizing team for giving this opportunity to me. Especially being a glaucoma specialist, all we think of is giving some drops to treat the intraocular pressure. But today I realized, especially after ma'am's talk, that we can do so much beyond that. And just because the patient has low vision, we need not just leave it at that. So today I'll be talking about basic things about visual fields. So what is this? What is visual field? It's defined as the area that is perceived simultaneously by a fixating eye. So Traquair was the first one who defined this as an island of vision in the sea of darkness. So it depicts that the visual field is a three-dimensional model. So when we're looking straight, it's not only left and right, up and down, but also it's in the forward and backward or the depth perception. So all these things together constitute a visual field of a patient. Coming to the normal visual field limits, so whenever we are interpreting or thinking of visual fields, uh, unlike how we see the patient, when we have a visual field report in our hand, we always keep the right visual field in the right hand and left in the left hand. So that's when we need to perceive it as how we see rather than the opposite side as when we examine. So this is of the right eye and this is the left eye. This corresponds to a physiological blind spot. So as you can see, normally nasally and superiorly it will be about 60 degrees. Inferiorly about 75 degrees. Temporally, since we don't have the nose obstructing temporally, and also there is larger retina, we have more temporal vision. So temporally, now when I'm looking straight, I can see almost till here 100 degrees, whereas nasally we'll be able to see lesser. So the same thing is depicted in this picture, wherein superiorly and inferiorly it is 60 and 75, and nasally and temporally in this way. So whenever we define visual fields, we tell it in terms of whether it is central or the peripheral. So within 30 degrees of fixation, which we usually measure, is called as a central field, whereas peripheral is 30 degrees and beyond. So why do we need to know about visual fields? The patient is 6'6". What else we need to know? Why should we know till where he's able to see? So mainly it's to recognize variation from normal so that we can detect any abnormalities and many diseases wherein the vision may be 6'6", but the visual fields are compromised can definitely affect the patient. So just by doing a proper visual fields, we can detect the disease. And also in known patients, like in that case of glaucoma or neurological diseases, who already have, but we keep on regularly doing many visual fields, then we can make out that whether the patient is progressing. So though the intraocular pressure may be normal or the vision is still maintaining at 6'6", but when we see the visual fields, if it is progressing, then we need to change our treatment strategy. So there are many indications, but the common ones which we usually constitute for whom we need to do are those with glaucoma suspects and known glaucoma patients, as I was just telling, to know the baseline and also for the progression. And thirdly, neurological conditions like if they have stroke or infarcts or any brain-related diseases. So these people are the ones who are usually having some visual field defects. So we saw what is visual fields and why we need to know, but how do we check this visual fields? Right from 1932, there have been many ways to measure this visual fields, but the usual ones which we usually use is the confrontation test, which is very easy and can be done anywhere and by everybody. Second one is a static perimetry, and third one is the kinetic perimetry. So in the confrontation test, usually it is done between 60 to 100 centimeters distance has to be placed between the examiner and the patient. And this is done basing on the assumption that the examiner's visual field is normal. So we'll compare with the examiner, close the respective eyes. That is, if the examiner is closing the left eye, this right eye of the patient has to be closed. And then you bring the finger from a non-seeing area to a seeing area. So whenever the examiner is able to appreciate the finger, at the same time, even the patient has to appreciate. So if the same time he is appreciating, that says that that particular field of the patient in that quadrant is normal. Similarly, you repeat in all the quadrants for both the eyes separately, closing the each eyes separately. Kinetic perimetry, in this kinetic, the word means movement or something which is moving. So in this, the target is moved across the visual field until the patient detects it. So the target itself moves again from the non-seeing area to seeing area. They keep bringing it, and as soon as the patient detects it, they have to tell that yes, I can see, and then we mark the point. So there are various methods like clusters, Goldman perimeters, but what we usually use in our day-to-day life is a bearing screen or the tangent screen. So here there is a flat black surface which measures a center 30 degrees. We need to ask the patient to fixate on the central point, and then we bring this stick which has different color targets from the periphery to the center and then detect the visual field. Static perimetry, kinetic was where the target is moving, whereas static is the target is not moving. So in this, what will happen is at various visual fields, the targets are displayed, and the patient has to detect and tell when he's seeing and when he's not seeing. So the commonly used ones are the Humphreys automated perimeter and the octopus. So we'll just see a brief video about how to do a perimetry test for a patient. So once we confirm the MR number and whether we are doing the right patient, you take them inside, and then in the first menu we'll have various strategies. So usually the one asking for that, they would have mentioned what kind of strategy they need, like if it is central 30-2, 24-2 or 10-2. So for this video, we are particularly showing 24-2, which is one of the most commonly done visual fields. So we select the 24-2, and then we need to enter the patient's ID, the patient's name, and the date of birth. Date of birth is very important because in the visual fields, we'll be comparing it to the normal individuals. So at 60 years of age, the what he's perceiving, we'll be comparing it to normal. So we'll have to make sure you're entering the correct date of birth. And then we need to give the trial lens correction. So either we can make it manually or enter it in this, wherein the diffraction details of the patient, that is a sphere, cylinder, and axis. All the three has to be mentioned for both the eyes, right eye and the left eye separately. And then the machine gives this value, the trial lens value, which we need to place it in front of the patient's eye. Next, we go on to enter the pupil diameter and the visual acuity, that is BCVA of the patient for both the eyes. We need to then explain to the patient the procedure of the patient, that is, it is doesn't cause any pain and that it will take about 10 to 15 minutes. Is the audio audible? Okay, then. So this is the joystick that we give to the patient that they have to click. So there will be two parts of the test. First is the foveal threshold test, and then is the main test. So in the foveal threshold, there will be blinking light. Whenever they see the blinking light, they have to click. And in the second test, they need to fixate in the center, and then whenever they're seeing any kind of white dots, they have to click each time they see. Okay. So cover the eye which you don't have to test, patch that eye, select the appropriate trial lens which is required for this particular patient and place it in front of the patient's eye. Make sure the patient's head and chin are comfortably placed and the patient is not tilting back or tilting to the side, which can really affect the visual fields. So we have this up and down wherein we can make sure that the patient's eye is centered correctly. So the first and the second part of the test has to be done. As you can see, there are these white dots which are appearing here and there, and each time the patient has to click. So say one eye and then go on to proceed to the test the other eye. Once both the eyes are done, you can take the print option, take out the printout of both eyes separately. So you then scan it into a PDF format and then upload it into the patient's folder. But the newer machines, like if you have Zeiss Forum, then so here we'll have option of patient to upload the file. So in the newer machines like Zeiss Forum, directly from the fields, we can directly put it into the forum along with his other tests. So this is how you do a visual fields. If visual fields, doing them correctly is very important. So once the fields are done, this is how the report will come out. There are it's divided into various zones, wherein first zone it is of patient details, and second zone is fixation losses and reliability indices. This is what you have to look very properly. If there is XX or if it's being flat, that means if the patient has not done correctly and you need to repeat the test. No point in doing the whole test and it's not reliable and then we cannot do it again. So better do the repeat the test again. So, and number 3 is the gray zone. 4 is the raw data. 5 is total deviation. That is compared to the normal, how much it is deviated. And zone 6 is after accounting for the anterior segment pathologies. So we'll just see briefly about few commonly seen visual field defects. So whenever there are visual fields like this, wherein there is a superior arcuate scotoma, that is many black dots in the either in the upper field or lower field. Any guesses what this usually, what might be the disease when the fields are appearing like this? Yeah, I heard somebody. Glaucoma. Usually the glaucoma field defects will appear like this. Either there will be a lot of black dots either in the superior field or the inferior field, up or down. So this is usually a case of glaucoma. Whereas the main two things we have to differentiate is whether it is because of glaucoma or if it is because of any neurological condition. Whereas if it is maintaining vertical meridian, it is on the right side or the left side, especially if it's there on both the eyes, then these usually interpret that it is neurological field defects. Whereas glaucoma will be more of either upper or lower. Or in neurological, it can also be that only one part of the eye in both the eyes is affected. That is one quadrant. This again depicts that it is more of neurological fields. Some cases like this wherein they can have dense double arcade scotomas, that is superior and inferior completely involved. Only the central field, like what we usually tell is a tubular field the patient will have. The patient may be having 6/6, but because of this tubular field, he will be affected so much. So we need to make sure we do visual fields in such patients. Like examples are those in case of retinitis pigmentosa, advanced glaucomas, or those who have undergone panretinal photocoagulation. So recent advances is we have this virtual reality perimeters wherein this VR headset is placed over the patient head and then we give a joystick to them for them to click whenever they're seeing. So this is very easy as it is very portable and we don't need this huge HFA machine where we cannot take the machines. So to conclude, visual fields help in diagnosing and monitoring progression of various diseases. It's an essential part of routine exam and a visual field exam done well will aid the doctor in not only diagnosing properly but also give appropriate treatment. I thank Dr. Janani ma'am, MB sir and everybody else to giving me this opportunity. Thank you.